This is Sally Schessler, Director of Education for the Allergy and Asthma Network, and welcome to our 2018 webinar series titled Advances in Allergy and Asthma. Our webinars are brought to you by the American College of Allergy, Asthma, and Immunology as well. The goal of our webinar series is to share guidelines-based information and resources with you that are relevant to your life and your practice. This series is a part of how we at the Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. This webinar is titled Vital Partnerships for Patients, Caregivers, and Physicians, Shared Decision-Making in Immunotherapy. We are pleased to be joined today by Dr. Don Bukstein. Dr. Bukstein is a board-certified allergist, immunologist, pediatric pulmonologist, and is currently working with Allergy Asthma Sinus Center in Milwaukee and Madison in Wisconsin. He holds staff appointments at multiple health centers in both Milwaukee and Madison, including St. Mary's Hospital, Madison, and Waukesha Memorial Hospital in the Milwaukee area. Dr. Bukstein was also a former clinical professor in the Department of Pediatrics and former clinical professor of family practice at the University of Wisconsin-Madison for over 30 years. He worked as a pediatric intensive care physician for 17 years at St. Mary's Hospital Medical Center. He is also a fellow of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, and the American Thoracic Society. Dr. Bukstein received his medical degree from the University of Missouri-Columbia. He completed his internship and residency in pediatrics at Children's Medical Center of Dallas, University of Texas Southwestern Medical School. He also completed fellowships in allergy immunology at National Jewish Hospital and in pulmonary medicine at the University of Colorado. He is also co-director of the Problem-Based Learning Institute that is an industry leader in teaching interactive education techniques. Dr. Bukstein is an internationally renowned allergist and pediatric pulmonary specialist. He has numerous articles published in such peer-reviewed journals as Pediatrics, American Review of Respiratory Disease, the American Journal of Managed Care, Allergy, Pediatrics, Allergy Proceedings, and Annals of Allergy and Journal of Clinical Outcomes Management. As a speaker, he gives approximately 50 presentations each year regarding asthma and allergic disease, and he has a special interest in the role of shared decision-making in improving outcomes. Dr. Bukstein, we're so happy that you actually have the time to be with us today. You're a busy person. We're looking forward to hearing from you about shared decision-making.
Thank you, Sally, and I want to thank everyone that's online today, those of you looking out your window and with lots of snow, and I'm actually in Florida giving some talks, and it's quite nice here, so all of you, welcome. Today we're going to talk about something that's near and dear to my heart, and that is allergic rhinitis. I, like many of you, have allergic rhinitis, and thus am concerned with control of my medical problem as well as my patients. But more to the point, I want to talk about the vital partnership between patients, caregivers, and physicians with regard to shared decision-making. We have a number of objectives today. I usually, at the beginning of most of the time when I'm talking to people about allergic rhinitis, whether it be other physicians, caretakers, or patients, I like to put out my objectives and then actually answer the objectives and then go about discussing them. I certainly would rather be discussing this in an interactive format, but this will have to do for right now, and I encourage you to write down questions as we go along. Our objectives are to review the prevalence and economic impact of allergic rhinitis. I'll answer that one right now. It's increasing in prevalence, and its economic impact is increasing both in direct and indirect costs in the United States. We define what's meant by difficult to manage allergic rhinitis. That's both from the patient and the physician perspective. And we'll talk in detail about that there are a significant percentage of our patients that don't get better with the wonderful over-the-counter medications, nasal steroids, non-sedating antihistamines that are available over the counter and that need more intensive therapy and treatment. And we want to recognize that the optimal control of allergic rhinitis is currently not being achieved, and I think I'll hopefully make that case, and discuss the impact that difficult to manage allergic rhinitis has on our quality of life and the multiple comorbidities that exist with allergic rhinitis. And then finally discuss, and I will spend a fair amount of time doing this, the shared decision-making process and how it applies to options for long-term immunotherapy as a way of managing difficult to control allergic rhinitis and conjunctivitis. And when I say going forward a difficult to control allergic rhinitis, I'm including their allergic rhinitis conjunctivitis. I think it all comes down to our patients. Here I'm going to give a history of a typical patient, actually a real patient, name changed, but Judy T. She's a 25-year-old graduate student we saw, and she presents to your office now due to frequent nasal problems, especially congestion drainage. In the last year, her symptoms have progressed to year-round, but worsen in the spring and fall. And one of the first things you need to do with allergic rhinitis or any chronic disease especially is to find out what is the patient's PPI. Now, I know all of you are saying PPI, that means proton pump inhibitor. No, PPI should mean to us the patient's perception of illness. Dr. William Osler, a famous physician in the early 1900s, thought that was the most important part of the patient history, was that patient's perception of their illness. So when you ask Judy, what's the perception of your illness? She tells you 5 things. I remember having seasonal allergies as a teen, and I used over-the-counter antihistamine. That's pretty good. And as an adult, I used oral antihistamines. They don't really seem to work anymore, and they make me sleepy during my classes that I attend and teach. My nose is always stuffy, and I always have drainage, and I'm tired of suffering from these darn nasal allergies, and I feel fatigue constantly. And for a grad student, that's not a great idea. And recently, my primary care physician prescribed a generic fluticasone nasal steroid spray. I really don't like taking it, and probably don't take it as much as I should. We did a review of symptoms, and she denied discolored mucus, fever, sore throats. She has sinus headaches during weather changes, worsening congestion due to strong odors and perfumes, and tiredness plus fatigue due to waking off at night with her nasal congestion. Her past medical history, she's had an urgent care visit a month ago due to fever, headache, colored mucus. She had normal sinus x-rays and is instructed to use her sinus irrigation for treatment. No antibiotics have been prescribed. She improved from nasal sinus. The nasal irrigation really improved her, but she hated feeling all that stuff draining down the back of her throat, and she has no other medical illnesses. Environmental survey and history suggests she lives in an old rural apartment near a heavily wooded area with old carpeting, new pillow, and fairly new mattress. Lives with a roommate of 2 years and has a 5-year-old cat. Her school is also located near a heavily wooded area. Denied smoking or smoke exposure. Family history, her mother and maternal aunt both have chronic allergies and have been on allergy shots when they were younger. Social history, she sings in her church choir, but is often frustrated from clearing her throat due to postnasal drainage. She enjoys outdoor sports such as tennis and golf, but has experienced symptoms outside in the past 2 years during the spring and fall and tends to minimize her exposure and not do the sports that she actually likes. On her exam's pretty unremarkable. Well-developed, well-nourished, appearing female, no acute distress, but she's rubbing her eyes and nose. Vital signs are normal. She's not obese, body mass index 20. I wish mine were 20 again. Eyes normal, tympanic membranes normal. Her nose, pale, moderately edematous, inferior terminates with obvious clear rhinorrhea bilaterally. No polyps noted, transverse nasal crease, septum normal. And I think it's important here, I'm going to make a point to really view the septum. If you're going to be treating her with topical nasal steroids, maybe nasal antihistamines, other nasal sprays, you want to make sure that the septum's intact, because one of the complications may be irritation of the septum as you introduce other nasal sprays. Throat, cobblestoning, pharynx is clear with clear postnasal drainage, chest is clear. So I'm going to wait a second. I want all of you to form your impressions and your evaluations. Or would you even do an evaluation on this patient? Or would you just say, boy, this sounds like typical run-of-the-mill allergic rhinitis, no big deal. She's having a lot of problems. I'll just try another nasal steroid or another nasal antihistamine, or put both of them together, or put her on oral steroids. What would you do evaluation-wise, or would you just treat? Well, let's just say we just treated her. It was recommended that Judy obtain an over-the-counter corticosteroid nasal spray to use twice a day, plus a topical OTC antihistamine eye drop that she could use 2 to 3 times a day, kind of when she needed it. She apparently did well and didn't return for her follow-up appointment. However, she returns 2 years later in September, taking her corticosteroid nasal spray almost daily, May through now, when her symptoms are at its worst in the fall of the year. She stated the nasal spray and eye drops seemed to help over the last couple years, but she still had lots of symptoms during her bad season. She's also got a horrible cough now, and she feels at times like she's wheezing, and she kind of constantly has a sinus headache. Her exam is abnormal again for erythematous bulbar conjunctiva bilaterally pallidemmatous inferior turbinates with copious clear rhinorrhea bilaterally with loose, deep, productive cough, mild wheezing, and her O2 saturation is 97%. So now we see that her chest exam is normal. You get some sinus x-rays report from urgent care where she's been with sinus infections in the past year, and they're negative. A CT scan was also ordered, which was clear. And since Judy wanted to know what she was allergic to, you, let's say, are a primary care physician, and you ordered some blood testing for allergies, which showed the following. Her serum immunocaps were highly positive to pasture grasses, short and giant ragweed, some mold spores, and cat dander. So Judy returns for a follow-up visit after the weather has turned cooler. She notes that she's not much better. She's just having a congestion at this point, but not much better. Her husband told her that to quit snoring so loudly after the weather turned cooler, and he complains about it frequently. She still feels fatigued, even though she's not on any oral antihistamines. And she stopped all her medication 2 weeks ago when her allergies got better. And she wants to discuss what her options are and hopefully prevent such frustrating symptoms next summer and fall. Well, what do you do now? What do you discuss with her? What is her own personal preferences of what to do, and how do you establish that? So here's where we begin to talk about shared decision making. I think this is the point where you're going to have to do some significant shared decision making with Judy. What is shared decision making? Well, shared decision making, I think we all would agree with this definition, is the involvement of the patient with their providers in making healthcare decisions that are informed by the best available evidence about options, potential benefits, and harms, and that are considered really patient preferences. You know what it involves? It involves the use of really evidence-based information, okay? And the doctor or nurse practitioner, or physician's assistant, or medical assistant may be the one, and the best one, to go through this with Judy and help her in recording and really implementing some of her preferences. I usually ask everyone when I'm talking about shared decision making to raise your hand if you've heard of shared decision making, and usually every hand in the room goes up. And then I ask, have you used a shared decision making aid to help you make these decisions with your patients? And almost no hands go up. Well, why is shared decision making important? I think would all agree that it's important because it's in the healthcare provider's interest as well as the patient's interest to do shared decision making, and should become pretty much the norm for educating our patients. I hope the further discussion we can clarify this concept and outline some actions that you can take that may help with the shared decision making process and make it better shared decision making. Shared decision making in allergic rhinitis in a patient like Judy is a process, again, where you're going to work with the patient around treatment management, self-management, and support goals, and share information about options and preferred outcomes that you both are looking for. So what would you say to Judy are the pros and cons and benefits and risks of immunotherapy? How can you be sure that you went over each one of them and presented them in a kind of egalitarian fashion so that your own preferences didn't color that discussion too much? And do you know about any shared decision-making tools or aids that you or your staff could use to help with this discussion? I want you to hold that thought for a minute. And now we're going to backtrack just a little bit. And I want to convince you how important that shared decision-making process that we're going to talk a little bit more about and even introduce to you a shared decision-making aid is. 59% of our patients with allergic rhinitis think that their symptoms are moderate or rate their symptoms as moderate and severe. 20% of patients believe their healthcare provider doesn't take their symptoms seriously. And like Judy, only 1 in 8 seek treatment. Here you can see that allergic rhinitis is a significant health concern. Over 50 million people suffer with it annually. High comorbidities of asthma, sinusitis, otitis media, sleep disruption. It has impact on quality of life, impaired physical and social function, disturbed sleep, irritability, depression, and high economic costs. Well over $20 billion. The most recent survey suggests in indirect and direct costs in the neighborhood of 20 billion plus a year. Again, you can see that it's underappreciated, underdiagnosed, and undertreated. It's kind of the Rodney Dangerfield of diseases, if you would. The clinical diagnosis is often delayed. Patients are told they just have sinus or rhinitis. 31% aren't satisfied with their treatment. 88% want more long-lasting treatment. 47% are on multiple drugs, and many take over-the-counter medications. These comorbidities overlap, and we discussed a few of them: asthma, otitis media, sleep disruption, rhinosinusitis. It seems like Judy has all of them except for the otitis media. It's not only important to the patient from a pharmacoeconomic sense, but it's important to employers and society. From an employer perspective, it's the most common cause of absenteeism of any chronic disease in the workplace, and the second most common cause of presenteeism. Almost 25% of workdays productivity loss from missed work days are due to allergic rhinitis, and you can see it here compared to many of the other chronic disease processes that may affect absenteeism, presenteeism. Presenteeism, it just means productivity in the workplace. I'd like to give you a kind of impairment and risk stratification that we use. Impairment and risk, we use this model all the time in asthma. Impairment in allergic rhinitis, we've talked about, you should be able to check this off if your patients are adequately treated, that they have no troublesome symptoms, they don't need rescue medication, they have no daytime fatigue, normal nasal airflow, they can breathe through their nose easily, they do all the things at work and school and leisure activity they want, and overall their quality of life is going to be good. The risk is, if you don't treat it adequately, that they're going to have exacerbations where they have sinusitis or poor sleep. They're going to have comorbid conditions we talked about, and their disease may progress. And hers has certainly seemed to progress into having now more asthma symptoms. I know you all ask these questions, I'm sure, every time a patient comes in, but the use of a standardized questionnaire is just absolutely necessary. We can't ask the questions the same way each time and get what we call a control chart, where we're actually looking at a number, kind of a hemoglobin A1C, if you will, for allergic rhinitis, unless we have a standardized form to work off of. So we use, as many others do, the RCAT, the Rhinitis Control Assessment Test. It asks 6 questions, and it rates them on a Likert scale from 1 to 5. How often did you have nasal congestion? Did you sneeze? Do you have watery eyes? What other allergy symptoms do you have to interfere with your sleep and activity? And how well are they controlled? And if you have a level, an RCAT score of 21 or less, these patients may have problems. You'd like to have a score of 30 or more, answering all those questions optimally. But scores of 22 to 30 really say the rhinitis is pretty well controlled. But if you have an RCAT change of over 3, let's say you start at 18 and you improve to 21, that's considered very meaningful. So patients like to have a number that they can relate to, whether it's a diabetes, a hemoglobin A1C, and here the RCAT gives you that. Now we know from the Joint Task Force and practice parameters in the allergy community and the European Academy of Allergy and the area European guidelines. There are many guidelines. I'm not going to go through all this, but most of them don't recommend first-generation antihistamine because of the side effects. They all recommend avoidance, but sometimes that's very difficult with outdoor allergens, dogs, cats, dust. Most of the allergens, it's difficult to have great, perfect environmental control and avoidance. Nasal steroids are our most effective therapy. They're first line in moderate, more severe persistent disease. I think everybody agrees with that. Mast cell stabilizers, leukotriene antagonists have some efficacy, but certainly no better than the currently available non-sedating antihistamines. So a key here is participation of the patient. If you can't get them to become activated, an active partner, and the best way to do that, in my opinion, is through shared decision making, then you're not going to have very good adherence to therapy. And it's a choice, oral versus nasal route of administration of therapy. Do they want to combine treatment versus just individual therapy? Corticosteroid nasal sprays versus antihistamine nasal sprays? And what choice of pharmacologic therapy do they want? And then, is pharmacologic therapy not adequate, or do they not want pharmacologic therapy? They do their own risk assessment, and then you talk about allergen immunotherapy. 3-prong approach is always minimize symptoms, reduce symptoms with pharmacologic therapy, and then consider altering the immune response with immunotherapy. It's really a shared decision-making exercise of what makes the most pharmacoeconomic and practical sense to that specific patient. So that patient is going to take in all these things we've already talked about in assessing their asthma control, and you should help them do that. Every 6 months, you should be assessing signs and symptoms, quality of life, whether you're adequately communicating with the patient and they're happy with their therapy, whether you want pharmacotherapy, are their comorbidities controlled, And are they even taking their medication? Is that the reason some of the other factors aren't optimal? And why are my patients like Judy doing better? Well, most of the time it's probably poor adherence, or the therapy just isn't effective, and over-the-counter nasal sprays, nasal steroids, or prescription nasal steroids may not be always effective. Allergen avoidance may be impossible, or the patient's not willing to do it. They're not going to get rid of their beloved cat or dog. Immunotherapy is not suggested. Recently, I've been working in inner city clinic where many of our patients have had long-term allergic rhinitis and have never been offered immunotherapy. And when offered, they are readily would like to partake and try immunotherapy. Are his nasal and eye, or her nasal and eye problems really due to her allergies? Do we have the right diagnosis with Judy? And is it time, if we're a primary care physician, nurse practitioner working at a clinic, time for specialty care to help not only with initiating immunotherapy or other medications, but certainly shared decision making? And why aren't we meeting Judy's goals? That's a discussion we have to have with Judy. It's the right therapy for the right patient at the right time. Why do we even want to talk to her about immunotherapy? Well, one, it's the only natural therapy that we have. It decreases symptoms. It decreases sensitivity. It can significantly reduce outpatient services and costs by limiting those chronic sinusitis, asthma costs, and may offer lasting remission. This is sometimes quite important to the patient. May prevent the development of new allergies and reduce the severity of existing asthma and allergic rhinitis. And then, is Judy really a candidate for immunotherapy? Well, you have to go through a checklist. Do we have the right diagnosis? Do we have the appropriate clinical manifestations? Is it IgE mediated? Okay, does she have positive skin tests or immunocap tests, blood tests that really suggest aeroallergens, which we have good relevant allergens for? And has she looked at her value equation? Is the benefit over risk acceptable to her and to the prescribing physician? Are some of the medication side effects acceptable to her? Does she have a goal of long-term disease modification? And may this help her asthma in some way, help her get her asthma under some better control without increasing her medication use with regard to her asthma? So immunotherapy for asthma, SCIT has been around for over 30 years. I already said it's our only natural form of therapy. It's demonstrated all the things we've talked about. Prevents new sensitization in monosensitized subject, progression of rhinitis to asthma. Again, we don't know exactly how long immunotherapy needs to go on, but at least 3 to 5 years. And it shouldn't be just limited, in my opinion, and many others, to just those patients failing medical management. There may be other reasons why somebody wants to try a course of immunotherapy. Now we have a great shared decision-making aid for immunotherapy, and I'm excited about this. As you see, I was one of the committee members on an endeavor by the Allergy and Asthma Network and the American College of Allergy, Asthma, and Immunology. Some real experts listed below came together and developed a aid that you can use in your practice. This is an online aid that the patient can use separately, or one of your staff can go over this with the patient. Both are acceptable. And it's at allergytherapy.acaai.org. And I encourage you, I have some screenshots. The first part of this tool or aid kind of tells the patient about their allergic rhinitis, gives them an idea of the different options, medical versus immunotherapy with regard to management. It explains what immunotherapy is and introduces the allergy shots or subcutaneous immunotherapy and the allergy tablets or sublingual immunotherapy, and puts them in perspective with their pros and cons. I won't go into detail. You can go through this aid independently and see that it very nicely compares these two options of immunotherapy, their benefits, their risks, and really puts it out there in a number of different ways that enable the patient to make that healthcare decision. We really need to do this as a healthcare decision, not only in this case to control their symptoms, but maybe as a preventative, certainly as a self-management tool. They may want to choose immunotherapy. And what this is doing is really, this shared decision-making going through this is really explicitly recognizing a patient's right to make a decision about their care and making sure they're fully informed about all the options that they have. And, you know, we really have to provide them with some sort of evidence-based information, which this is, on the likely benefits and risks of this intervention, immunotherapy, slit and skit, versus non-intervention, doing nothing or continuing on the current medical intervention that they have. And it's really oftentimes a negotiation and compromise, recognizing that the clinicians bring a certain something to the table and that patients bring a different, equally important form of expertise to the table in making this shared decision-making. Because really the single biggest problem with the important part of communication between the patient and his caregiver is the illusion that it's occurred. So oftentimes we as caregivers feel that we've communicated well, but we haven't. That's why when you're going through this shared decision-making aid, many of it forces what we call teach back. So the patient has to really say what they're learning and answer questions along the way of going through this shared decision-making tool. So in the end, it's Judy's perspective as opposed to the physician's perspective. Judy doesn't want these disruptive symptoms, especially with sleep, waking up her husband. She doesn't want daily living limitations, not being able to play golf or tennis during the times of year when she would play. She wants to get rid of the comorbidities of sinusitis, maybe help her asthma. Her medication isn't working very well and it's costly. She has the full cost buying it over the counter. The physician wants to control her inflammation. He knows that her RCAT scores aren't good. She may not be adherent when he looks at her pharmacy refill information. There's a huge bother factor. If Judy's having lots of comorbidity, it's a bother not only to Judy, but to the office staff that are frequently answering questions and maybe trying to find a place in the schedule for an acute exacerbation of her allergic rhinitis or one of the comorbidities. And there's a significant cost to the medical system. So many healthcare providers say they do shared decision-making. Whenever I go, everybody says, well, I already do that. Why are you talking to me about that? Well, here's a little cartoon. It says, best thing you can do is give up smoking, drinking, and fried foods. And the patient says, well, what's the second best? Patients want to do certain things, but they don't want to do other things. So there are a lot of barriers for the physician. We're already doing it. It's too difficult. There are time constraints. I don't have the experience into doing these shared decision-making aids. I don't like fooling around with the computer. Doesn't fit into my system I work for, their clinical pathways. We don't have an implementation strategy. And finally, some of us are just too lazy. Here's the idea that some physicians have, paternalistic: when we want your opinion, we'll give it to you. But really what shared decision-making is not a paternalistic, but it's an informed choice. Of course, we have patients that say, I'm sorry, doctor, but again, I have to disagree. They come in with a lot of internet information. So it's the shared decision making is really that in the middle shared decision where the patient is informed, you know what's important to the patient, and together you make a decision. The reality check is most of us don't do shared decision making, and I'm mea culpa. I don't do it, haven't done it as well as I should have in the past. If you look at studies of over 1,000 audio tape clinical encounters containing over 3,500 decisions, you can see that only 9% of them really entailed good shared decision making. So the 6 steps of shared decision making: you invite the patient to participate, you present the options, hopefully using a good shared decision making aid, which makes it easier for you. You provide information and benefits risk, you elicit patient preferences, you facilitate the family, and then you have a breather. You let them go back and talk about it, digest the information, the patient and or the family, and then they can come back and you can assist with the implementation of the decision that they've made with your input. Now, there are many other ways to do this, but this is just one paradigm of good shared decision making. So it's not a one and done process. When it's well done with a properly trained staff, and here the physician may not be the best one to do this. It may be the most empathetic one in your office, which oftentimes may be your medical assistant. So again, there are other ethical reasons to do that. There are malpractice reasons. Washington State has done a study that shows it dramatically decreases malpractice claims if patients have done shared decision making about a disease process. And again, legitimately, you can charge for an extended office visit because of the time and complexity of shared decision making. And there are many areas of oncology, respiratory, and GI medicine that even require shared decision making for getting paid for a certain code. The aids, they come in DVD, online, multimedia. There's no end to how we can create good shared decision-making aids to help our patients clarify and communicate their goals to us and us to communicate to them in a better fashion. This is just a model of how we do it in our office. We have staff registering the patient, giving out the questionnaire, 5 minutes. The medical assistant goes over vital signs. I do a history, physical, get their goals, their PPI, patient perception of illness. I may tell them, okay, now my nurse is going to do shared decision-making with you. She does the education, the teach back, the shared decision-making, and we follow the patient up. It doesn't take 5 minutes, granted, but the whole process, I'm only in the room for 10 minutes or so, but the process does take about 20 minutes. It's not easy. The right thing to do is based on your perspective. Nothing's easy, and there are always 2 sides to every story. Allergic rhinitis is not a trivial disease. Let's do our best, I say, for patients like Judy. Allergic rhinitis can lead to a negative impact on quality of life and sleep, cognition, daily activity, and learning abilities. I remember when I went into practice, a young lady named Colleen working at McMaster and then the University of Wisconsin, this is over 30 years ago, was forming a questionnaire. She called it the SF-36, which looked at quality of life. And at that time, I must say, admit, I wasn't that interested running an ICU in quality of life and chronic disease. But she made the point, and she wanted my allergic rhinitis patients. In her previous studies at McMaster, allergic rhinitis had as much or more impact on quality of life as did asthma. And so she was interested in collecting more allergic rhinitis and asthmatic patients to give this questionnaire to. And again, this can affect their daily activity, learning abilities, and it's associated with substantial economic burden because of presenteeism and absenteeism. Remember, there are over 50 million people that have allergic rhinitis. Patients with allergic rhinitis oftentimes don't get adequate control, and they move from one nasal steroid to another over-the-counter medication to another without ever achieving good control. Shared decision-making should be used in helping make the decision on immunotherapy, whether you use subcutaneous immunotherapy, sublingual immunotherapy, the shots or the pills, depend on a number of different factors. And for each patient, one factor may be transportation for one patient. For another, it may be cost. For another, it may be risk of side effects. Every patient has their own risk-benefit equation, and you need to help them find and solve that risk-benefit equation and figure out what is the most valuable care you can deliver to them. And depending on the comfort of the provider and the specialty referral to an allergist may be appropriate. And I just want to remind you that as an allergist, as well as a pulmonologist, that patients with allergic rhinitis symptoms that aren't controlled on medication, and most of our patients now have option of getting very good medications, and they're maybe having side effects, they need to try to identify those triggers more. Or they want to do more, have more shared decision making about immunotherapy. Those are excellent reasons to refer to your local allergist. So now we have time for questions and comments. And I want to thank Sally. I want to thank Allergy and Asthma Network and all of you for putting up with me for the last 45 minutes in discussing allergic rhinitis, and with a real emphasis on doing more shared decision making in our practices. Thank you.
Well, thank you so much, Dr. Bukstein, for all your input today. It's fascinating to talk about how this can make such a big difference in the care of patients. We have a couple of questions, but please go ahead and type your questions in now for Dr. Bukstein, because he has some time to answer some questions. One of them is that, the question is, you talk about the amount of time it takes to do shared decision making in the office. Is this something that gets kind of better and quicker with time?
It does. There are two ways to administer a shared decision making aid. One is to have the patient do it on their own, and this shared decision making aid that I discussed that made by the College of Allergy and the Allergy and Asthma Network is online and can be the patient can be directed to it. So we direct some patients to it, and others, our medical assistant may go through it, especially if literacy and other things may be a problem, go through it and answer the question. It really only takes about 5 to 7 minutes for them to do it with one of the nurses.
Okay, well, here's one question. It says, would you repeat the online address for the tool?
Yes, I can certainly do that. Let me find that address, and I'll try and show it too, because nothing like showing it.
It always helps the best.
Let me see if I can find it. I think right here it is. Here we can have it. I'll make that bigger. It's allergytherapy.acaai.org. And you can find the shared decision-making tool there and a lot of other resources at the American College of Allergy, Asthma, and Immunology.
Okay. Well, somebody just wrote in and said that they've used the tool before. They've gone through it, and they said it seems very user-friendly and that they appreciate having that available.
That's super. That makes me feel very good, and I'm sure it'll make all the other committee members feel good too.
Well, there you go. Well, you said, another question is that you said it is not a one and done process. And the question that the person has is how do you keep your staff motivated to continue doing shared decision making over time?
That's hard. I think it's hard to motivate any of us to do something over time. But what we do is I think many of the staff I found really want and anticipate in a positive way the patient coming back and making that decision. We all have what we think may be the best decision for the patient, but that may not always be the decision they make. And we have to support them in the decision they make once they're fully educated as to the pros and cons and the science and evidence that they need to consider. But again, there's so many things that enter into that decision. It may be, in our case here, Judy has such a workload that she can't come in on a regular basis, okay, to get an allergy shot, and that oral immunotherapy may be the best solution, even though she says, well, maybe the shots I could treat more allergens that I'm allergic to. Still, I want to go with the pills or tablets with sublingual immunotherapy because it's the major ragweed and grasses that are my main allergen, and those are the ones that bother me the most.
Okay, you talked about the perspective of the patient and the physician perspective for shared decision making. What happens when the physician doesn't think that the patient's what they want to choose is the most appropriate course of action for them?
That's a hard one. And I think what you do there is if it's not totally, and these are decisions that are not clear cut, they're not black and white. You don't do shared decision making when really there's really one decision to be made. Somebody comes in with sepsis and you have to start antibiotic. You're not going to have them do a shared decision making about whether they should start antibiotics or not. But these are decisions often dealing with long-term therapy, chronic disease, procedures. And it's interesting. Patients are very pharmacoeconomically savvy, and oftentimes they may choose something that isn't as expensive. You think they always choose the costly medication, the more expensive option. Actually, the opposite is true. If, though, they're making decisions that you don't feel are best for them, knowing them, then certainly you can redo shared decision making. Often she may say, oh, I'm going to stick with medication, even though you know that immunotherapy with Judy may work better in the long run, and then revisit the shared decision making at another time, a few months later, let's say. So again, just because you've done it once, you're not one and done. You have the patient consider the options, they come back, you try something, you may redo shared decision making as you progress forward in treatment of a chronic disease.
Okay. Well, so you go through the next question is you go through shared decision making, and then the patient chooses something that might be a problem with their insurance. How do you get around problems like that?
That probably is one of our biggest problems because we should have all the up-to-date insurance information when we're doing shared decision making, because cost is always a factor. The problem is with many managed care plans and insurances today, they change the cost and copays of options monthly, okay? And so that one's a hard one to get into. What we do is, before we do shared decision making, we try to do a little research. If it's pretty easy and we can get it easily, then we do it ourselves, or we ask the patient. You need to go and ask your insurance company, with the plan that you have, what are going to be the costs of sublingual versus cutaneous, and the information. Most of the time for our major insurers, and certainly for Medicaid and Medicare, we know, because it's pretty uniform, we know what the costs are going to be. Okay, so we can establish those and give them to the patient. With myriad of health plans, oftentimes we put that onus on the patient that before they come in for their final shared decision, they have to call and find out what the costs are going to be. We give them the codes and they call their insurer and find the costs.
Well, that sounds like a great solution. Well, those are all of our questions today. If everybody would please just like to check out this web address one last time, allergytherapy.acaai.org. Dr. Bukstein, if we could go back to the questions slide, then we'll just move through our last few slides before we're done for the day. So I would like to thank Dr. Bukstein for your presentation today, and also thank you, our participants, for listening today. We'd like to ask you to join us next month for our April webinar. We're going to be joined by Dr. Rushi Gupta. She's going to be speaking on school issues, plans, policies, peers, and pizza parties. And that's going to approach food allergies. She's going to join us on April 26th at 4:00 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page of our website. Please download the handouts from the control panel. If you have any difficulties, please email me using the link in the email you'll receive tomorrow. Be sure to visit the website of the American College of Allergy, Asthma, and Immunology to access the shared decision-making tool for immunotherapy. Visit our website for guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma, and so much more from our partners at the American College of Allergy, Asthma, and Immunology. That's at allergy@asthmarelief.org. Thank you again for joining us today. We look forward to having you register to be with us next time on Advances in Allergy and Asthma. For the staff at Allergy and Asthma Network, this is Sally Schessler. We wish you a great and a healthy day as we work to breathe better together.